A very good evening, good afternoon to all the students and colleagues and my dear friends out here. Today, I'm going to talk about a very important topic which comes many times in your theory examinations and sometimes even in your viva voce when we are having a case of respiratory system. For example, a patient of lung abscess or a patient who has been posted for lung resections. So even though I will not be going into the details of one lung ventilation and various aspects, because that is a full chapter in itself and a full lecture in itself, but yes, a few aspects of lung resections which you should be aware of, and the anesthetic management and the perioperative goals in those scenarios should be clear to you. So, but before we go into the various types of lung dissections, you should know what are the types of lung dissections which one commonly does in the operation theatre. This involves pneumonectomy, lobectomy, segmentectomy and wedge resection, metastasectomy, pleural surgeries, and airway surgery. So, what is pneumonectomy? Pneumonectomy is basically removal of one of the lungs which is diseased. Basically, it is removal of the lung which is diseased by an open thoracic surgery approach. Now, the various other surgeries of lung resection can be performed either with minimally invasive approach or an open approach. So, lobectomy is basically removal of one of the lobes of the lung. I will be telling you what are the different lobes in both sides of the lung, the right lung and the left lung. And then coming to segmentectomy, meaning removal of one segment, or wedge resection. Wedge resection is basically removal of one triangular piece of lung tissue which is diseased. So why do we go on to this conservative type of lung resection? Is that we want to preserve as much natural lung as possible so that the patient has adequate post-operative respiratory function to sustain a productive life. Then comes removal of metastatic lung deposits, that is metastatectomy. In this, various lung conditions, for example, various cancer conditions wherein the secondaries are deposited in the lungs, they are removed to actually give him a palliative kind of an approach for prolonging life in a fruitful manner. Then comes pleural surgeries. Now, coming to pleural surgeries, in pleural surgeries, there can be either pleurodesis or entire removal of the pleura. This can be done in the case of either long-standing pleural fibrosis or pleural adhesions or pleural depositions. Then, lung resections can also be part of airway surgery. Airway surgery is basically the lower airway surgery, the carinal and the bronchial growths, for which you will require opening of the chest. So I have also given the diagrams here, which you can see, the wedge resection, the lobectomy, the pneumonectomy, and the thoracotomy incision. Basically, it is given on the lateral, posterolateral or the anterolateral approach to the lung. So this has to be crystal clear before we proceed further. Indications for lung isolation or one lung ventilation. Now, this is very important. There are three types of indications: absolute, relative, and relative strong and relative weak. So, what do you mean by lung isolation or one lung ventilation? Indications where only one part of the lung will be ventilated and the other part will not be ventilated to allow for the surgery to proceed. So, you must remember that in certain situations, you need to give one lung ventilation. One lung ventilation is a dangerous procedure which risks hypoxia and hypoxemia, and hence you should be very selective in your approach towards conditions which require one lung ventilation. So the absolute indications are protective isolation in case of massive hemorrhage or infection, like lung abscess. Control of ventilation disturbance, bronchopleural fistula, giant cyst or bullae, bronchial disruption, and major trauma. Unilateral lung lavage. For example, in the case of cystic fibrosis, sometimes you need to do a unilateral lung lavage to remove the inspissated secretions. Otherwise, if you do not give one lung ventilation and occlude the lung to be operated, then it will result in soiling of the normal lung. The same thing happens with infection or abscess. And another one is VATS surgery, that is video-assisted thoracoscopic surgery. Then coming to relative indications for lung isolation, relative strong thoracic aortic aneurysm, pneumonectomy and upper lobectomy, and relative weak indications is phageal surgery, middle and lower lobectomy, thoracoscopy under GE. Okay, so preoperative pulmonary function test, bedside test or pulmonary function test, calculation of predicted post-op. I will be coming in detail to all these details. I'm just going to mention these parameters to you so that you understand that these are the tests which are more important when we are dealing with a case of lung resection. In general, all the bedside and other pulmonary function tests have to be done. But this predicted post-operative PPO test is also important to predict survival and to predict the incidence of post-operative complications. And there are measures which can be used as a marker of gas exchange and exercise testing. Preoperative exercise tolerance. As per the British Thoracic Society guidelines, you also need to do a spirometry to measure the FEV1 before any lung resection. If FEV1 is normal, then you can also measure the diffusing capacity as DL, carbon monoxide. So reduced post-operative DLCO correlates with the risk of post-operative pulmonary complications and mortality. If predicted post-operative FEV1 30 to 40% and predicted post-operative DLCO, all these things are used. These two actually form the best predictor for complications after lung resection, right? So what are the two important predictors? Predicted post-operative FEV1, forced expiratory volume, FEV1, and PPO DLCO. VQ scan method may be used for pneumonectomy, but this method is not available in all institutions. And the PPO values are calculated by a formula. I'll be coming to it a little later, right? But here again, I have mentioned so that you can understand the importance of this predicted post-operative value. Now, coming to lung segments. As I told you, sometimes segmentectomy or wedge resection is performed to preserve as much normal lung as possible and to remove the diseased lobe. So, on the right side, what you have is the right upper lobe, right middle lobe, and the right lower lobe. In the right upper lobe, there are 3 segments. The right middle lobe, 2 segments. Right lower lobe, 5 segments. Then on the left side, you have just 2 lobes, left upper lobe and the left lower lobe. The left upper lobe has 4 segments and the left lower lobe has 5 segments. So if a patient is having a preoperative FEV1 of 63% and he is scheduled to undergo a pneumonectomy of the left side, which means that entire left lung is going to be removed, which also means that 4 plus 5, that is 9 segments of the lung are going to go in this patient. Then the predicted post-operative FEV1 is equal to preoperative FEV1, that is 63%, into 1 minus the number of segments removed, which is 9, 4 plus 5, that is 9, and the total number of segments. How do you calculate the total number of segments? 3 plus 5 plus 2, that is basically 10 on this side, and 9 on this side. That is 19 segments total. So basically, this formula is 63% into 1 minus by 19, that is 33.2%. So a patient who is having a preoperative FEV1 of 63% following a pneumonectomy of the left side will only have a predicted post-operative FEV1 of 33.2%. So this is important to understand that this patient will need post-operative ventilation for a long time, post-operative respiratory support for a long time, and should be extubated very cautiously and should also have a good respiratory support program. So again, explaining to you, You have to understand that all these segments are very important to be able to give you the adequate amount of respiratory function to the patient in the postoperative period. And that is why we are very, very careful in the preoperative